Welcome to this essential guide on understanding and managing amenorrhoea and oligomenorrhoea. As a woman or a healthcare professional, it's crucial to be informed about these subjects. Today, we will explore the definitions, etiology, and management of both amenorrhoea and oligomenorrhoea. Amenorrhoea refers to the absence of menstrual periods. It is subcategorized into primary and secondary causes. Primary, failure to commence menses, absence of menarche, girls aged 16 plus in the presence of secondary sexual characteristics such as pubic hair growth and breast development. Girls aged 14 plus in the absence of secondary sexual characteristics. Secondary, cessation of periods for more than 6 months after the menarche, after excluding pregnancy. Oligomenorrhea refers to irregular periods with intervals between menstrual cycles of more than 35 days and or less than 9 periods per year. Disease of the hypothalamus can reduce the secretion of GnRH. This, in turn, decreases the pulsatile release of LH and FSH from the anterior pituitary gland, causing anovulation. Functional disorders, e.g., eating disorders, exercise, high-level exercise or eating disorders suppress GnRH production and subsequently lead to low estradiol levels via ghrelin and leptin. Severe chronic conditions, such as psychiatric disorders, thyroid disease, and sarcoidosis. Kalman syndrome, an X-linked recessive disorder characterized by failure of migration of GnRH cells. The anterior pituitary gland releases LH and FSH, which are necessary for menses to occur. Common causes of pituitary amenorrhoea include prolactinomas represent 40–50% of all pituitary tumors. They secrete high levels of prolactin, which suppresses GnRH secretion. This causes anovulation, amenorrhoea, and galactorrhea. Other pituitary tumors, e.g., acromegaly or Cushing's syndrome, gonadotrophin deficiency from mass effect of the tumor plus hyperprolactinemia induces menstrual irregularities. Sheehan syndrome, postpartum pituitary necrosis secondary to massive obstetric hemorrhage. Patients can have varying degree of anterior pituitary hormone deficiency. Destruction of pituitary gland, such as radiation or autoimmune disease. Post-contraception amenorrhoea, prolonged use of contraceptives can cause long-term downregulation of the pituitary gland and irregular, absent periods or lack of ovulation, which persists. This is most commonly seen with Depo-Provera, where it can take up to 18 months for menses to resume. Polycystic ovarian syndrome, PCOS, more commonly causes oligomenorrhea, but can present with amenorrhea. It causes high androgen levels, leading to hirsutism, acne, and weight gain. Turner syndrome, 45X neuro, a genetic condition that causes amenorrhea, failure to develop secondary sexual characteristics, and almost universal infertility. Patients display a range of other features associated with the condition, including a short stature, webbed neck, and aortic coarctation. Premature ovarian failure. This is defined as primary ovarian insufficiency before the age of 40, associated with menopausal symptoms such as hot sweats or night sweats. Hormone profile tests show low estrogen levels with high FSH. Disease of the adrenal gland can affect ovulation. Late-onset, mild congenital adrenal hyperplasia is an autosomal recessive inherited condition, which is caused by partial deficiency of 21-hydroxylase, an enzyme required for synthesis of cortisol and aldosterone. Women present with early development of pubic hair, irregular or absent periods, hirsutism, and acne. High levels of 17-hydroxyprogesterone are present in the blood. Any obstruction to the normal menses flow causes concealed bleeding and pain. Asherman syndrome can occur secondary to instrumentation of the uterus, typically following SMM, surgical management of miscarriage. This damages the basal layer of the endometrium, which causes intrauterine adhesions which fail to respond to estrogen stimulus. Imperforate hymen transverse vaginal septum, a mechanical obstruction. Mayer-Rokitansky-Kuster-Hauser syndrome, characterized by agenesis of the Mullerian duct system in varying degrees. This translates to congenital absence of the uterus and upper two-thirds of the vagina, and therefore a cause of primary amenorrhea. There is considerable overlap between oligomenorrhea and secondary amenorrhea. Common causes include PCOS, contraceptive hormonal treatments, perimenopause, thyroid disease, diabetes, eating disorders, excessive exercise, medications e.g. antipsychotics, antiepileptics. Firstly, the menstrual irregularity must be classified into oligomenorrhea, primary or secondary amenorrhea as per the definitions above. A focused and detailed history covering details of the periods, including what age the periods began, cycle length, development of secondary sexual characteristics, associated symptoms, and past medical, surgical history will help to identify the cause. A stepwise approach is necessary to identify the abnormality. Pregnancy test, blood tests, thyroid function tests, TFTS, and prolactin. FSH, LH, estradiol, progesterone, testosterone. 17-hydroxyprogesterone, congenital adrenal hyperplasia, karyotyping, if suspecting a genetic abnormality, ultrasound scan to visualize ovaries and pelvic anatomy, progesterone challenge test to elicit a withdrawal bleed. A bleed suggests there are adequate levels of estrogen, however, the patient is not ovulating, i.e., PCOS. No bleed could mean there are very low levels of estrogen or an outflow obstruction. Treatment will depend upon the exact cause of the oligomenorrhoea/amenorrhoea. However, the general aims include regulating periods. The contraceptive pill in the form of either the combined COCP or the progesterone-only pill can help to regulate the periods and keeps the lining of the womb thin, thereby reducing the long-term risk of endometrial cancer. The intrauterine system, IUS, can be useful in stopping or significantly reducing duration and flow of menses in women suffering from heavy, irregular periods. Hormone replacement women with premature ovarian failure insufficiency should receive cyclical hormone replacement therapy with oestrogen and progesterone if they have a uterus. This treats the symptoms of menopause, decreases the risk of cardiovascular disease, and maintains bone density to prevent osteoporosis. Calcium and vitamin D supplementation is also recommended, often following a bone density scan. Symptom control. A number of medications can be used to manage excessive hair growth, including particular types of the COCP, e.g. yasmin, cyproterone actitate, spironolactone, and finasteride. Acne treatments include antibiotics and topical treatments, such as benzoyl peroxide and topical retinoids. Patients with severe acne could be referred to a dermatologist for consideration of isotretinoin, Roaccutane. Lifestyle advice. Hypothalamic amenorrhoea secondary to eating disorders or excessive exercise require a strict regime to increase body fat and stimulate GnRH production, which should help to reintroduce the menstrual cycles. Women with polycystic ovarian syndrome, however, need support with a healthy living schedule consisting of a balanced diet and regular exercise. Some patients would be suitable for weight loss medications such as orlistat and statins if they have high cholesterol. Treating underlying disorder. Both hyperthyroidism and hypothyroidism can result in menstrual disturbances. Hypothyroidism, the decreased T3-T4 causes upregulation of TRH, which stimulates the secretion of prolactin, therefore LH-FSH is inhibited. Hyperthyroidism, increased sex hormone-binding globulin SHBG secretion, secondary to high T3-T4 reduces the ratio of free bound estradiol required to trigger the LH spike necessary for ovulation. Assessment of thyroid function with a blood test and appropriate treatment with levothyroxine, carbimazole, or propylthiouracil is necessary. Radioactive iodine may be suitable in selected cases. Improving fertility. Clomiphene is used to stimulate ovulation as a means to treat infertility. Metformin can be used in polycystic ovarian syndrome to induce ovulation, as well as treating the insulin resistance commonly associated with this condition. It also has a role in regulating periods and reduces circulating androgen levels. In vitro fertilization, IVF, would be available to women as a last resort. Surgery. Surgical intervention is the primary treatment for pituitary tumors and genital tract abnormalities. Pituitary adenomas are most commonly removed by a transsphenoidal approach. Thank you for joining us in this educational journey on understanding amenorrhoea and oligomenorrhoea. Stay informed and take proactive steps to safeguard your health.